Sandeep Bhutan from Sightsavers to talk about mechanized refraction, auto ref, auto refraction, all that modules. Yeah. Dr. Sandeep, your presentation is there, or? Yeah. There, huh? Okay, okay, we'll ask some. Can one of you, some of you check on that? Yeah, yeah. Yeah. Yes, doctor.
Right. Thank you, sir. I thank the organizers and the chair for giving us an opportunity to talk about this topic as such. Being in line with the whole topic of the session around how to use technology, so I've modified the topic slightly. It's around automated screening for detection of refractive errors, and because I know other speakers are talking about adults, I'm focusing on pediatric as such. And again, just a declaration that we have no personal or organizational commercial interest in any of the devices, and all the data and the technology that has been described is from public sources. We don't have direct personal kind of usability of any of these devices. So again, these are the outline of where I'm looking at. We don't have to talk about undetected refractive error and the significance of that to this audience. We already know that's a big problem and forms a major proportion of both blindness and visual impairment, not just globally, but in India also. And some figures which everybody knows, we already have an estimate around 20-25% population requiring some sort of refractive correction. But even then, saying that refractive errors can be easily diagnosed and effectively treated with spectacles is a line that requires a lot of thinking, because even though it is theoretically quite simple, it still is the largest cause that goes around. So again, focusing on a specific group, which is pediatric or childhood refractive errors, it forms a significantly more difficult problem because of the difficulty of finding children, plus the skill and other things involved. And moreover, we also know that developmental and other aspects of the refractive errors, if not treated at this age, are much more devastating as compared to adults. So the talk is looking at how refractive errors in children are looked at. We already have these figures that a huge number of children, around 90 million, are visually impaired. And during this process, it's not about refractive errors. We're also able to look at other eye diseases like allergies, infections, which although not visually impairing, but can have other implications. So looking at that, Sightsavers, the organization that I represent, we looked at childhood eye health as one of the priority areas, looking at around the big scope of this problem, which is close to 1.2 million government schools and close to 220 million students. All of these developmental aspects where this is the most vulnerable groups. Overall health status of the child is important, not just the vision. We also know that vision is going to have a large impact on the learning. Also, it gives us an opportunity looking at the health-related behavior and the overall development of the child. And that's the reason why we looked at school health as an important area. And here is where the identification of the problem that requires a technology solution comes in. The conventional approach to refractive errors is fairly simple for children. Train teachers, which is the approach that we look at, let them identify, screen the children for significant refractive errors, send in a refraction team which can do the refraction of the children who are identified or suspected, dispensing of good quality glasses, monitoring compliance to glasses, whether children are wearing it or not, and also looking at overall impact on their quality of life. Sounds fairly straightforward and should be simple, but when we actually went into implementation, from January to December, this is the data where we approached around 3,000 government schools across 6 districts in North India. Focus was on coverage and strengthening of existing systems because we wanted to be a scalable thing across all districts through the national programs. We also looked at using existing resources like teachers, ophthalmic assistants in the government sector, other NGO partners who are available, and also engaging with other educational departments like SSA and RBHK where possible. The numbers were amazing. We could screen close to 1.5 million children with the conventional approach, could refract 62,000. Prescription was around 16,000. And these numbers were looked at. But when we analyzed our data, we looked at these challenges that were there. The biggest challenge was coverage. This is a huge number of schools distributed across, finding children out of school was a bigger problem. So getting enough coverage of this program was really difficult, even with screening almost for 15,000 teachers. Quality both at refraction level, screening level, dispensing level, it was another challenge that we were facing. Getting enough manpower to do good quality refractions at the site as well as dispensing was becoming a problem. Compliance both from screening to refractions, from refractions to children actually getting glasses, and children once they got glasses to wear them. Overall cost of the program, depending on logistics and others, was again an issue that we had to look at, and closing the loop for that matter, because it's not just limited to creating refractions, other ones. So again, as it's true to about everything, the rule of technology is everything that can be automated will be automated. And here again, we looked at what are the technology options that would be an ideal solution. And again, a spoiler alert that we couldn't find a solution as yet, but there were things that we looked at. Ease of use, it has to be usable by lower scale staff. It has to be highly accurate, reasonable accuracy. Speed of testing has to be there, operationally efficient. Durability and resilience, we saw some shows that very expensive equipment was being taken, but we need to look at durability. And of course, because if you're talking about scalability of refractive errors, it has to be low cost. It can't be massively expensive. So we looked at a couple of options, and this is where the whole concept of automated screeners or automated refractors came into play, which does take care of a portion of these problems, not all of them, but this is how we looked at them. So what is this concept of photo screeners or refractors? They have been around for a very long time. It essentially is a photographic instrument which take a photographic image of the eyes, red reflex, which is the principle of the Bruckner's test. But also there's an analysis involved which analyzes these images to look at any embryogenic factors in children. It also may detect other ocular misalignments and other sight-threatening conditions like cataracts and squints. Again, as I described, essentially it's an infrared camera which looks at the eyes and the undilated pupil, and it looks at the red reflex. It is effective in identifying anisometropias, hyperopias, but also other issues like eye misalignments, ptosis, lens opacity answer, others. Also, it is highly effective in younger children where we expect the refractive errors to be difficult to detect. These are few of the devices that are commercially available. This is not an exhaustive list. There may be many others which are in development. We're explaining some of them. But some of these are available commercially and have been used extensively with a lot of studies that have shown. The first of these which came up was the MTI photo screener, which is again a digital photograph. It was a manual photo-based device, but it was used extensively in a large group of people. It had very high referral rate, very good referral rates, and high screenability rates of around 96%. Because it was used in community settings, there was a high positive predictive value of around 75 to 80%, and at that moment it was looked at as a good device to be pushed. Also, subsequent devices like iScreen, which uses high digital quality photographs with a back-end analysis where the images are sent to a proprietary analytic software and it sends back the results. It does demonstrate high levels of sensitivity and specificity in a pediatric office setting, but in a community setting, we see that the sensitivity was equal or slightly lower than non-cycloplegic retinoscopies and other autorefractors. Some more devices which have come up recently, like the PlusOptic series of devices, which have been designed for vision screening, but have been approved by the FDA as refractors. Again, when done across pediatric facilities, not in the community, it had very high effectiveness data of sensitivity and specificity in the range of 85 to 93%, and false positive and false negative rates of 9.1 and 2.7%. Looking at some of these options, these devices could be useful for younger children. Also, again, a multitude of data has been available. The pooled figures tell us that all available technologies have their advantages and disadvantages, and most data is still available from clinical settings. We're still awaiting a lot of community-based settings, and we know that some trials are already on way. I'm aware of a couple of them by Arvind and Elbrasad who are already doing some of these community-based trials, and it would be really good to get those community-based data in, and also looking at the operational efficiency, because that is another challenge that happens on these things. Some other vision screening devices which are being done at research level, like the iSpy 2020, which is automated computer software which tests the visual acuity, stereopsis, and color vision. The Diopsis method, which is a VEP-based mechanism, which not only checks the vision, it also looks at optic nerve and visual cortex. The RebiScan, which is an abrometer-based device, But all of these devices are more of research tools than community application, but I kept them there just to complete. So in general, we look at all photo screeners were reasonably effective for detection of high refractive errors and non-intermittent strabismus, but generally handheld screeners underestimated hyperopia and overestimated myopia, whereas some also overestimated astigmatism. Ambient lighting conditions, which is a problem in the community, affected most of the devices, some more to the other. And also the refraction data that was obtained from them was not regarded suitable for direct prescription. It did require either cycloplegia or in most cases, subjective acceptance. But there are other considerations which are more important from a programmatic perspective, which are on these aspects. We look at cost, as Madam also asked about. If you look at scaling up, setting up, maintaining these devices, what is the cost and how will we look at scaling up? At what level can they be deployed looking at this consideration? At community level, at primary care or service centers? Effectiveness, we need to look at the accuracy and can it give it a large amount of coverage that can be reached to provide impact. Also looking at requirement of secondary procedures. So if a optometrist or a trained vision technician is required to do the subjective, what is actually the utility going forward? And also looking at efficiency of work per unit device versus average, comprehensiveness and continuity, and of course, additional context like availability of power to recharge these devices, security of these devices, and servicing when they are taken into the field. So having said that, we definitely do not want to get in the technology trap, wherein automated systems not only amplify the efficiencies of a system, they're also likely to amplify the inefficiencies. So before we go into any such procedures, we also have to look at availability of staff to carry out subjective acceptance, linkage with good quality spectacle delivery mechanisms, ensuring high compliance rates, and monitoring value for money for these devices going in before going for scaling. Thank you.
Yeah, thanks.